Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our quick sessions in which we summarize together one of the top articles. And today we are going to discuss together the key messages from the UK confidential inquiries into maternal death and morbidity. This is the Embrace. Embrace latest report, guys, is talking about very important points and they have a key message for us. There is no wonder that we greatly depend on the results of the embrace in our practice. We are going to address the high risk groups. We are going to focus on women who, let's say, in the very term that embrace itself chosen for them, they are the missing voices. So women who are in as missing voices in the UK are mainly the deprived areas and women who are not really having an apparent reason for mortality, and they may be overlooked, they may be underestimated. So it's not like a usual report of embrace, but this one in particular includes topic-specific reviews into the care of women who died from cardiovascular causes or hypertensive disorders, early pregnancy disorders, and mental health-related accidents. So I think this report is very, very important. We have key facts and figures, as you can see. They have told us that 9 of the deaths which occurred between March and December were directly attributable to COVID-19 infection. However, However, psychiatric disorders and cardiovascular disorders are now responsible for the same number of maternal deaths in UK. This is a red flag. Now we are having women who have psychiatric disorders just equal to the number of women died from cardiovascular disorders. This is very important. And we still have a fourfold increase in mortality rates among women from Black ethnic backgrounds, and almost twofold increase in women from Asian ethnic backgrounds. This is very important for the exam too, but I'm not going to focus only on the exam questions. I'm going to focus on points that can be applied into our clinical practice in means of taking history or referrals to specific clinics and so on. We still have thrombosis and thromboembolism as the leading cause of direct maternal deaths during or up to 6 weeks after the end of pregnancy. Suicide and substance abuse are still the main cause of late maternal deaths. Nearly 40% of deaths occurring within a year after the end of pregnancy is because of maternal suicide. So this is really devastating. Okay, now I want to focus on the specific maternal groups that the report have focused on. We have specific key messages for care of maternal mental health problem and multiple adversity. Mental ill health remains one of the leading causes of maternal death in pregnancy and first postnatal year. This is late maternal deaths. At least half of them died by suicide, and the majority of women who died from substance misuse had multiple adversity. This is in particular is very important while you are taking your history from the patient. Try to look further. Try to not simply consider the woman presentation in the moment issue. Don't take her words like just now. No, try to read beyond her words. If she's talking about substance misuse or if she's talking about um, feeling unwell now, just try to get back. Go back. Go back in time and ask her whether she was feeling okay for the last months, whether her last pregnancy, how it was, what about her support back home, and so on. This is very, very important. Specialists, perinatal mental health teams should be involved, and that's why you are the one who is going to figure out that there is a current problem, so you are going to refer her to the specialist perinatal mental health, right? Specifically, if this woman is in her first pregnancy, specifically if this woman is teenager or young age, specifically if this woman is having a kid with mental health, or a kid with a congenital abnormality, or a kid with a genetic disorder back home. This means that this pregnancy is a burden for her, right? So just try not to focus on the in-moment issue. Don't also forget about sleep disturbance. We rarely ask about sleep for any pregnant woman, but they say that sleep disturbance is very common in relation to mental illness. So if she's telling you that she's having insomnia, or she's having multiple nightmares, and I don't know, I'm not like sure if if I really want to go to sleep, because when I go to sleep I get nightmares, and I know I want to sleep, but I cannot do this. This is insomnia. And insomnia has a very common relation to mental illness and psychological difficulty. Okay, what about women with diabetic ketoacidosis? The trick about women with diabetic ketoacidosis is they have a complex presentation. We are not only dealing with um, the acidemia or the lactoacidosis in her blood, and the bicarbs and so on. No, this woman is not only diabetic, but maybe also she's having a complex presentation. Maybe she's hypertensive. Maybe she's having hyperlipidemia. Maybe she's having a cardiac problem, and so on. So please don't forget about this. Another very important point is that DKA can occur even with low glucose levels. So don't just forget about this fact and exclude the diagnosis of DKA because she's having hypoglycemia or normal blood glucose. Your main diagnosis will be dependent on the criteria for DKA. Okay, the alteration is the bicarb, high bicarb, the acidosis, of course, and the raised ketones. Okay, and the lactic acid levels, and also we have the positive. I'm sorry. Yes, the raised anion gap and the elevated base deficit, and the low bicarb. Okay, so we have a criteria. Maybe you are going to have two or three of them, but it's not a must that the glucose levels should be high. Another very important point is several women with pre-existing diabetes become pregnant with raised hemoglobin A1C at booking. And of course, later on, they are going to have sudden intrauterine deaths in third trimester. That's why we should be aware that both raised hemoglobin A1C at booking and poor glucose control in pregnancy will increase the risk of sudden intrauterine death in pregnancy, especially after 36 weeks. This is one of the most common causes of IFD in third trimester. So keep your eye open on the glycosated hemoglobin, and keep your eye open on the glucose control. Okay, the next one will be also with diabetic ketoacidosis. They told about the steroid administration, and that steroid administration can precipitate to DKA. However, on the other side, you can have extra control, or maybe I won't say extra control. I would say a harmful hypoglycemia that results from the over control with insulin in case of steroid administration. So some doctors are going to prescribe steroids for its obstetric causes, okay? And then because they know that steroid is going to cause this woman hyperglycemia, they are going to increase her insulin requirements. And this could lead to hypoglycemia and potential developmental delay to the fetus. Okay, so try to balance your care. try to be alert for the state or the glycemic state in this woman. Specifically, I'm telling you specifically, after 36 weeks, we should discuss with our patients the risks of steroids and the benefits also. Lessons on cardiovascular care. I don't want to repeat myself all over again. We have talked so much about cardiovascular diseases in pregnancy, and I will put the link for our previous discussion on valvular diseases in the description of this video. Please, please consider wheezing, which do not respond to standard asthma management and exertional syncope as red flag symptoms. Don't consider it as physiological presentation during pregnancy. When you have wheezes that does not respond to treatment, or when you have multiple visits from the same woman to the emergency department, this should alert you. This should tell you that something is wrong. So when you have a repeated presentation, this should prompt senior and MDT review. Pregnant women who present with palpitation, you may think that this is okay, this is something physiological. However, when this palpitation is accompanied with breathlessness or dyspnea with exertion or palpitation at rest, this should require further investigation. Also, the common symptoms associated with ischemic heart disease can develop over a very short time frame. So when you just suspect that this woman is having MI, you should do an action. Okay, treatment of hypertensive disorders. We have something called National Patient Group Direction. When we imply this National Patient Group Direction, we have widened the implemented referral outside not only the midwives and pharmacists to prescribe aspirin. No, it has become widened beyond them. So this helped us a lot to prevent preeclampsia. However, we still see cases of severe hypertension and preeclampsia. So we still need to do more effort, right? So we as a staff can sometimes not recognize the prolonged induction of labor as a change in the mother risk status. So we should focus on this. If this woman is having a prolonged induction period, this could make her at risk. Okay. Also, when we have this prolonged induction of labor in such women, we should make like a review, or let's say a record for the doses of prostaglandins that she has been given over several days. This is very, very important. So they say that earlier input from the MDT to facilitate communication with the mother about their preferences with broader insight into their cumulative risk factors may have led to different care pathways. So it's all about counseling. It's all about counseling. And it's all about keeping your record updated, the doses, how much has she been induced, how is she's going on with her vitals, and so on. Last but not least, the care for early pregnancy disorders. Those ladies in particular are the missing voices, vulnerable and young women who become pregnant. Sometimes they are not going to be apparent for you. Sometimes they will be disclosed. So you should put them in the red zone always until proven otherwise. They need additional safety measures. They need enhanced follow-up pathways. And make each visit for those women, either for follow-up visits for miscarriage or prescribing contraception or STD screening or smear tests. Make each of these visits an opportunity to educate them regarding the red flag symptoms associated with ectopic pregnancy and the awareness about the symptoms that may reduce deaths, like bleeding, like chronic pelvic pain, like please, if you feel you are not supported while at home, you should tell me. Do you feel safe at home? Is everything is okay? Why you are having this bruise on your abdomen? I'm keen on knowing why you have this bruise on your face. Maybe she's having a domestic violence, right? So the report is telling us that 3 women died from ruptured ectopic pregnancies after receiving thrombolysis. And this is very important regarding patients who are prescribed thrombolysis in particular. Why? Because they said that not all collapsed and shocked women is going to have pulmonary embolism. So the prescription of thrombolysis should be undertaken after fast scan, focused assessment with sonography for trauma. Any one of you who had taken the ATLS, Advanced Trauma Life Support, know very well what is fast. When we do a fast scan, we are excluding intra-abdominal pathology or bleeding, and only then we can prescribe thrombolysis. Okay, I think I have reached the end of the report, and thank you so much for being here today. The report is very important. Please try not only to take it on the exam perspective. I want you to focus on the points we have talked about in your clinical practice. I wish you all the very best, and see you later, inshallah.